Good afternoon from New York City, and good morning to those who are west of me. I am Dr. Garfield Clooney, the 123rd President of the National Medical Association. Welcome to today's webinar entitled The Triple Threat Plus One. This morning in this beautiful city, I was greeted by a temperature of 7 degrees, and now it's about 16 degrees. Old Man Winter reminds us that he is alive and well, and COVID-19 is following his lead. This pandemic has remained steadfast with ebbs and flows longer than any of us expected, and this year's COVID-19 co-conspirators, influenza and respiratory syncytial virus, have joined to threaten this nation's health. On the fringe is MPox, which seems to be decreasing in prevalence, but we still need to be aware and know how to counsel and treat patients who may become infected or are at risk. During this webinar, you will hear experts from the National Medical Association talk about the latest information concerning these viruses and the most up-to-date management. So get ready to receive essential information that we all need as we continue to navigate these health threats. Now it is my pleasure to introduce our moderator from the great state of Rhode Island, an expert in pediatric infectious diseases, Dr. Tanya Rogo. Dr. Rogo is Associate Professor of Pediatrics at the Warren Alpert Medical School of Brown University, where she's the Program Director of the Fellowship in Pediatric Infectious Diseases and the Medical Director of Antimicrobial Stewardship at Hasbro Children's Hospital in Providence, Rhode Island. Dr. Rogo completed her undergraduate education at the University of North Carolina at Chapel Hill, and then received her medical degree and Master's of Public Health and Tropical Medicine from Tulane University. Dr. Rogo is a member of the NMA's COVID-19 Task Force on Vaccines and Therapeutics and also the Council on International Affairs. And today, Dr. Rogo will serve as our moderator. Dr. Rogo.
Thank you, Dr. Clooney, and welcome to everyone. I'm so glad you can join us here today. We have a great program planned for you. Before we begin, I just wanted to give some instructions. First, this session is accredited for 2 hours of CME. And the learning objectives are to express the impact of COVID-19 variants on vaccine efficacy and treatment, to describe RSV prevention strategies in infants and young children, to explain updated indications and dosing of influenza vaccines, and to employ the recommendations for MPox vaccinations and treatment. For all the attendees, for each speaker, there is time allotted for questions after each speaker, and we also have time allotted at the very end of the webinar. And we ask that you put all of your questions into the Q&A box. Please do not put questions in the chat. Put them in the Q&A box, and they will be answered after each speaker and at the very end. And also, we do have a pre and post test questions that will display before each speaker, and then at the end, each speaker will answer the questions. All right, so we'll go ahead and begin with our first speaker. So we have 4 panelists with us here today. We have Dr. DaCosta, Dr. Whitley Williams, Dr. Tricia Shaw, and Dr. Dal Hewlett. And our first speaker today, who will discuss COVID-19 vaccines, variants, and long COVID, is Dr. DaCosta, who is a board-certified physician, immunologist, and vaccine and a subject matter expert on vaccine and immunotherapeutics development, who works for the Coalition for Epidemic Preparedness Innovations as a program leader for development of a broadly protective coronavirus vaccine, and works in close collaborations with partnering organizations, including the World Health Organization and the NIH. Dr. DaCosta, welcome.
Thank you very much, Dr. Rogo. Thanks for having me. So I'm going to talk today about COVID-19, specifically focusing on some of the new and emerging variants of concern, and also on long COVID, a few words on long COVID as well. We'll start with the pretest for this section of the presentation. And the pretest has 2 questions. The first question relates to the variants of concern section of the talk, which is, according to the WHO Technical Advisory Group on Virus Evolution working definition, a SARS-CoV-2 variant of concern is one that A, meets the definition of a variant of interest, B, is associated with an increase in transmissibility in COVID-19 epidemiology. C is associated with a decrease in virulence or change in clinical disease presentation. D meets all of the above criteria A, B, and C, or E meets criteria A and B and may be associated with an increase in virulence. The second question relates to the second part of the presentation, which is on long COVID. And the question is, which one of the following is true regarding post-acute sequelae of SARS-CoV-2 infection or long COVID? There's a single choice answer here, and is the first one option we have is among people with long COVID, a small minority of only 5% report having limitations to their day-to-day activities. B, there is a clear and unequivocal evidence that vaccines reduce the likelihood of getting long COVID and that they reduce the severity of long COVID among people who already have it. C, high-level evidence, grade 1 evidence, suggests that vaccination before SARS-CoV-2 infection could reduce the risk of subsequent long COVID. D, the impact of vaccination in people with existing long COVID symptoms is still controversial, with some data showing changes in symptoms while others did not. E, the percentage of people who have COVID and currently report long COVID symptoms increased dramatically from June 2022 to January 2023. So that's the pretest. So the next slide, which is the first slide presentation. And yes, and this just gives an overview of what I'm going to talk about today. So we'll start with a background that gives this sort of demographic landscape to the COVID-19 pandemic as things stand most recently. And this is based on the CDC COVID tracker. We'll look at trends in cases and deaths in the US. I'll then go on to talk about defining what SARS-CoV-2 variants are. We've heard all these various terms, variants of interest, variants of concern, etc. And a little bit about how these strains and emerging strains and variants of concern are named. We'll talk about the legacy variants of concern and the currently circulating variants of concern that are all based on the Omicron variant, subvariant. And subsequently, we'll look at escape from antibody production and efficacy by currently circulating Omicron and its descendant lineages. We'll then talk about efficacy of licensed COVID monovalent, bivalent vaccines, antibody-based therapies, and antivirals against these emerging variants and previously circulating variants. And finally, I'll say a few words on long COVID, also known as the post-acute SARS-CoV-2 syndrome. We'll go into definitions, some symptoms, some impact on specific organ pathology, and also some hypothesized mechanisms of pathogenesis, and a little bit on recent data emerging on long COVID. So on the next slide, this just is a background that sets the scene for the demographics as of January 25, which is very recent, from the CDC COVID data tracker. So just over 100 million total cases in the US, of which there have been almost 300,000 just in the most recent week prior to these data, and also over 1 million deaths in the US. You can see that there is a preponderance in some of the biggest states, more highly populated states, which include California, Texas, Florida, and Illinois, as being those that have the largest numbers of cases. And one might ask, where is New York? Well, New York and PA, where I am, follow immediately after those, the big four. On the next slide, we go into a little bit about the demographics without really belaboring this too much, that there are some preconceived notions about the case distribution based on a race and ethnicity basis within the United States. These are most recent data as of January the 28th, 2023, also from the CDC. And the first slide, on the first half of the slide on the left-hand side, we see that there are almost 100,000 cases, 95,000 cases, million, I should say, cases that have been used to look at race ethnicity distribution. And almost 1 million cases, 948,000, used to look at deaths based on race and ethnicity. And what we see here, the big caveat here is that these data are based on the ability of the CDC to actually go out and gather data that is available in the public domain. Now, reporting is always falls short of what you actually get. So caveat the interpretation of these data. On the left-hand side, we see that in terms of cases that amongst Hispanics and Latino population, where the percentage of the US population in this demographic is about 18.45%, we see a proportion of cases that's higher than would be expected based on that, and that's 24.5%. For the non-Hispanic Black population, which is the fourth bar down, we see that the demographic category is about 12.5% of the US population, and commensurate with that, about 12.4. So really no difference as expected, which might be counterintuitive to what we think in general. So again, here caveat, what is reported versus, lack of reporting for variety of reasons that we cannot go into in this limited time. And then finally, for the white non-Hispanic population, we see that 60% of the US population is made of this demographic, but only 53.6% are represented in terms of cases, which may be intuitive in terms of what we would believe would be the case. In terms of deaths, when you look at the Hispanic Latino population, you see that despite the 18.45% representation of the population, deaths are at 16.8%. Again, this may be difficult for some to believe. For the Black non-Hispanic population, you do see that there is actually very slightly half a percentage point more of deaths than those represented in the population, which again would be very difficult to reconcile with what we believe in general. And then for the white non-Hispanic population, you see 60% and then 63% of deaths. Again, probably a little bit counterintuitive. So I guess the story here is that there are limitations to these data when they're gathered based on the ability to actually report data that actually pertain to the true reflection of what's going on in the public domain. But they do give a sense of where things stand overall. So against that background, we look at some of the terminology that's used to identify variants of the SARS-CoV-2 coronavirus. And variants of interest is a term that you'll see that's being used that represents variants that have genetic changes that are predicted or known to affect the virus characteristics that include transmissibility, disease severity, immune escape potential, and a potential to escape diagnostic or therapeutic measures. And these are also identified to cause significant community transmission. Now, significant may be a very small proportion of the total, but indeed they do prevail. Or they may be in multiple COVID clusters in multiple countries with increasing relative prevalence over time, and also increasing cases over time. And there may be other impact epidemiologically that suggest that they're emerging as a risk to global public health. The term that you probably most frequently will see is VOC, or the variants of concern, which really meets the definition of everything I said previously for VOI, and through a comparative assessment has been demonstrated to be clearly associated with one of more of the following changes at a degree that signals public health concern on a global basis. So first of all, increased transmissibility or some sort of detrimental change in epidemiology, or an increase in virulence or change in clinical disease presentation, or a decrease in effectiveness of public health and social measures available or available diagnostics, vaccines, and therapeutics. So this is the definition from the WHO Technical Advisory Group for a variant of concern. On the next slide, there is a term that is not frequently used, and that's the variant under monitoring. So a variant that has genetic changes suspected to affect virus characteristics with some indication that it may in future pose a risk, but evidence of phenotypic or epidemiological impact is currently unclear. It's being monitored because of the suspicion that it may become in future a variant of concern. So a variant under monitoring is another term to be aware of. On the next slide, we go into a little bit of the nomenclature for the ancestral and other SARS-CoV strains. The ancestral strain you'll often refer to as being a prototypic strain, especially in vaccine or in vitro studies, or as the Wuhan strain, in clinical and diagnostic studies, for instance. There are groups that you'll see that you come across potentially, especially GISAID, which really studies the genetic makeup of these lineages. Next strain and Pango, they all are very prominent in the nomenclature of these strains. We'll come to more on that on the next slide. And the technical advisory group from the WHO worked together with these groups to really introduce a system that is more readily, easily applicable and usable by the lay public, and based on the Greek alphabet, as we all know, alpha, beta, gamma, delta, omicron. Previously circulating alpha, beta, gamma, and delta, with currently circulating variants of concern are pretty much Omicron and its descendant lineages. On the next slide, we really go a little bit into nomenclature, just to go into a bit of the legacy. We initially heard about the Pango lineage, which was the first to be used prior to the introduction of the alphabet system. And we can see here, I won't go into too much detail, that the emergence of these various circulating variants of concern over time began in 2022 September, and subsequently, or were first documented in 2020 September. And all of the alphabets that are now legacy variants are pretty much from various parts of the world really emerged at some point in 2020. Subsequently, Omicron reared its ugly head in November 2021, emerging almost simultaneously in multiple countries. And just a footnote there that the subvariants that we're hearing a lot about today, BA1, BA2, 3, 4, 5, and some of the more prominent descendant lineages, that BQ 1.1, XBB 0.1, XBB 0.1.5, all descendant from the Omicron. Next slide. Basically, a little bit more about Omicron, which was first reported from South Africa in November 2021. It was collected from a specimen that year in that country. And it's a variant that really has some very frightening, when you look at the graphics and the molecular structure of it, large number of mutations compared to previous iterations, even compared to Delta, which, as we know, has been responsible for much of the morbidity and mortality. Increased risk of infection as compared to other variants of concern based on these structural considerations. And also the multiplicity of descendant lineages, which have really evolved very quickly, some of which are currently wreaking havoc in terms of the propensity to cause larger waves, although these probably haven't panned out as we expect for reasons we'll talk about in a second. And other parts of the world, you know, XBB, which is very prevalent in the US, and others are continuing to gain ground in terms of their prevalence compared to their competitors. And just to go into some evidence base here, a lot of work is coming out on these, the potential for these emerging, currently circulating descendant lineages of Omicron to actually do something that is a little bit more than just increasing transmissibility, which is the tendency as they evolve, but also to begin to show a potential to evade the immune response. Now, this is an article from Cell, which is looking at in vitro work that was conducted by Wang et al. And published very recently, that shows that the most recently emerged group of subvariants that are prominently gaining ground, the BQ and the XBB subvariants, they demonstrated dramatically increasing ability to evade neutralizing antibodies, at least based on these in vitro data. These are based on samples taken from subjects who have been immunized with the bivalent mRNA booster. We know that Pfizer and Moderna have these booster vaccines that contain essentially the Wuhan strain and also a circulating variant of concern. And then subsequently, those also had breakthrough Omicron infection. So they're completely resistant to these sera from boosted patients, but also resistant to monoclonal antibodies. We know that bebtelovimab, which is the only one that is actually most recently was in use, is also showing that in vitro resistance to these strains. And so there are currently no clinically authorized therapeutic monoclonal antibodies effective against XBB and BQ. And the next few slides will talk a little bit more about this. Some very recent, again, from the New England Journal, a series of articles that really look at the evolution of the story of neutralization escape which possibly may, at least in theory, is thought to have a potential impact on current and future vaccines that target these emerging variants of concern. And essentially the story you're seeing here at the bottom here in the graphs at the very bottom is the in the first two monovalent booster subjects, as well as from 2021 and then subsequently 2022. And then on the very right-hand side, bivalent boosters. And the story is essentially the same. As these variants evolve going towards the right in terms of time and dominance, you get less and less of an ability to neutralize them based on sera taken from these subjects and used in vitro experiments to try to neutralize. And so this raises the concern that, you know, the newest vaccines that we have are less and less effective as these viruses emerge, so that these viruses are learning to escape the potential for neutralization by these modalities. And the next really is something that's a little bit counterintuitive to that. So we talked about in vitro, and you notice I emphasize that quite a bit. When you actually look at effectiveness of bivalence against severe Omicron infection, you find that hospitalization or death, there is a significant effect of bivalent boosters over monovalent boosters with a roughly 25 to 40% increase in effectiveness. So that boosters do have a role, because the obvious question is, are they redundant? But the bivalent boosters certainly do have a role to play based on some of this most recent data in the New England Journal. This slide, which essentially is the last slide in this section, really tells a story about the monoclonal antibodies that are used in treatment have been used in SARS-CoV-2 in the past, had been received emergency use authorization from the FDA and other regulatory authorities. In A above, we have a number of monoclonals and combinations I'm sure many of you are familiar with. And in B, we have antiviral drugs. So first of all, for the monoclonal antibodies, we see that if you look at the nice sigmoid curves that you expect for each of them in terms of, you know, neutralization as you increase a dose, and then you have a log phase and a plateau. That's the sort of standard curve for most of the strains. But you look at the orange and yellow graph bars at the bottom of each slide, the lines at the bottom of each slide, you see those are XBB and BQ subvariants or descendant lineages. And in each and every case, for all of the monoclonals, you see that they are not behaving the way they should. They do not present that sigmoid curve. They are lagging behind. They do not neutralize these viruses. And then you look at the antivirals on the other hand, we have three representatives here: remdesivir, molnupiravir, and nirmatrelvir, and they all have that sigmoid curve. So the story here is that while these viruses and the most recent and the most prevalent variants of concern based on BQ and XBB are able to are equivocal when it comes to vaccines, they're completely neutralized monoclonal antibodies that are currently available. And in fact, we know now that none of these monoclonals are licensed. Betovimab recently was de-licensed by the FDA most recently for this very reason. However, antivirals, at least in vitro, do seem to have a role. So that's just a very quick overview of the variants of concern. And I'll go into a little bit on long COVID before we wrap up this part of the presentation. So very quickly, long COVID, as most of you will have heard about, is the definition is based on a working definition by the Department of Health and Human Services here in the US in collaboration with CDC and other partners. And it's defined as signs and symptoms and conditions that continue or develop after initial COVID-19 or SARS-CoV-2 infection. There are a number of alternative names you'll see. The most common one perhaps you'll see is this post-acute sequelae of SARS-CoV-2 infection, or PASC. That seems to be a term that's being used mostly in research and some clinical studies. And also there are a few others: long haul, post-acute, long-term effects of COVID, and chronic COVID. So I've just taken a bit of departure from the normal formatting here to introduce blue here, because we know that the long COVID is somewhat ill-defined in terms of the cascade of symptoms or the evolution of symptoms, but we know there is some that are much more common. Here, they're divided into various systems, and the ones in blue are the ones we most commonly see or most commonly reported as long COVID symptoms. So fatigue, headache, cognitive impairment with memory loss, anosmia, hair loss, dyspnea, loss of appetite, sleep disorders, anxiety, depression, reduced quality of life. And as you can see, there are many others. And this is really based on a study that was done by Parker et al., reported in 2021 in the Lancet Respiratory Medicine. There are so many of these studies, I have to add, that look at the symptoms. So you'll see some variation here and there, but this is one that's good in giving a general view of the overview of symptoms of post-acute SARS-CoV-2 syndrome or long COVID. And this is one I'm not going to dwell on. I mean, just simply to say that there's impact on multiple organ systems, multiple different parts of the anatomy are involved with long COVID, which really indicates the systemic impact of COVID in the long term. And the reference is there, which I would encourage everyone to look at, by Davis et al. In Nature Reviews Microbiology. And just a bit on the mechanisms. Again, this is all beyond the scope of this talk. We could go on forever about this, but there are some key tenets of the underlying pathogenesis of long COVID that include immune dysregulation that may be associated with various pathogens such as herpes viruses like Epstein-Barr virus and human herpes virus 6 are thought to be potentially involved. There is the impact of the gut microbiome and virome on a persistence of SARS-CoV-2 and long COVID that results from that. There are thoughts about molecular mimicry from primed immune cells resulting in autoimmune effects. Also, microvascular blood clotting and endothelial dysfunction, as we know, is a key core SARS-CoV-2 underlying effect, and that this may have some effect in persistence and long COVID. And there is also thought to be some neurological basis potentially leading to dysfunctional signaling in the brainstem or vagus nerve that can lead to some of the more neurologically based effects of long COVID. Finally, I just wanted to go through a few of these recent data from the Kaiser Family Foundation, published in the National Center for Health Statistics very recently in late January, and accessed with permission from them. The percentage of people who have had COVID and currently report long COVID symptoms has been shown to decline in the 6-month period between June 2022 and January 2023. And this applies to both those who currently have long COVID and those who ever had long COVID but do not currently have COVID. So some of the key findings that among people with long COVID, about 80% roughly have limitations to their day-to-day activities, and about 30% characterize these limitations as being significant. However, when you ask about, are they really struggling with these symptoms, these limitations, only 5% of the adult population really have limiting effects on quality of life, and they're struggling. So that is perhaps lower than one might expect. In terms of the effect of vaccines, what do they do in terms of long COVID? The evidence is really very mixed, and there are a number of studies that have looked at this now, and some indicate that there may be suggestion that the that vaccination before the infection occurs, before you develop any SARS-CoV-2 infection, even breakthrough infection, could reduce the risk of subsequent long COVID. But the evidence for this is really low-level grade 3 evidence from case control and cohort studies. There is also some controversy about the impact of vaccinating those who have existing long COVID symptoms, especially when you boost them, with some data that show that the symptoms are mitigated and others that show that they're not. So there's a lot of the jury still out on the impact of vaccination on long COVID. And just finally, long term, it's really unclear what's driving the reduced percentage of people we noticed in the last 6 months or so who have reported long COVID, whether this is the mass wall of vaccination or other factors, epidemiological or otherwise, and whether or not this trend will continue in the future. So I'll stop at that point. Thank you very much for your time and for listening to this, and hopefully you'll be stimulated to learn a bit more about this rapidly growing field, both from the variants and the long COVID perspective. Thank you very much. I pass it back to Tanya. We do have a post-test. I should add, and for the post-test, of course, there will be a vote, as I understand it. And again, I won't go through each of the questions. I certainly will, once we have the vote and we have the result, we can probably mention what the correct result is at the time. Is that correct? Tanya, pass it over to you.
Yes. I think if you can just tell people what the answers are.
Okay.
Acosta.
Yes. So the first question is, according to the WHO Technical Advisory Group on the working definition, a variant of concern is one that A, meets definition, B is associated with increase, C associated with decrease in virulence, or D meets all the above. And the correct answer is actually E. It meets criteria A and B. That is, it meets the definition of a variant of interest. It's also associated with increase in transmissibility, but also associated with an increase, maybe associated with an increase in virulence. And we see that most people actually got that answer correct at 61%, which is great. On the next question, I don't see the next question up. Can we project the next question again, please?
Okay, maybe we'll come back to that at the
Okay.
end.
Okay.
I'm going to move along just for the sake of time. So we have a couple of questions. And so the first question is, how long does vaccine immunity last? And I'm going to piggyback on that a second question. If you can comment on the FDA's recent proposal that the boosters should be annual.
Yes, I'll try and comment on this very quickly, especially the one on boosters, because there's a lot of discussion around that and we don't have the time. So the first question was in terms of durability of the immune response. And we know that generally for the prototypic vaccines, what we saw was durability of an average of about 3 months before you see significant waning of the immune response, at least based on in vitro studies. And there's variations, from between 2 to 4 months, depending on which vaccine you look at. You look at the prototypic mRNAs, best-in-class vaccines. Generally, 3 months gives you you get good, at least in vitro neutralization. But if you look at actual effectiveness of the vaccines, there is some indication that there may be a little bit longer in terms of effectiveness. And we think this is probably due to the background of, for instance, CD8 T-cell responses that may drive some, vaccine efficacy beyond what you see with neutralization. So it's not a black and white answer, but certainly, there may be background T-cell responses and also B-cell memory and other parts of the immune system that kick in to give you durability beyond the nominal about roughly 3 months. And the second question, if you remind me again, Tanya, was about
Comment about the FDA's proposal to change
about annual boosters.
Mm-hmm.
Yes, and so the FDA is taking a position that would be akin to what we do with influenza, which would be to determine what the circulating variant at the time is, and then to include that in a bivalent, at least, vaccine. And there's a reason why it wouldn't just be a monovalent variant targeted vaccine, and then boost once a year. Now, in essence, that brings ease to the general public of not having to have boosters every few months, which is very good. It also, in theory, should be easier than influenza, because with influenza, you look towards the east and you say, okay, several months from now, it's coming out west, and this is what we need to put into the vaccine. And we've seen that the efficacy of those vaccines vary quite significantly from year to year. And there's always this complaint that, oh, well, I took the influenza vaccine and I don't, and I got influenza. That's quite a prevalent thing we hear. With SARS-CoV-2, because they are circulating variants, a lot depends on how they've evolved at the point in time that you want to immunize towards the end of the year. And it may be that they have just emerged and will persist, for another 6 months, year, and makes a lot of sense. Or it may be that they're at the tail end and they've been emergent and prevalent, for a year, and they may be at the verge of waning. So it's a bit of a Russian roulette, but at least there is a basis for including the Wuhan strain as well as your variant of concern, because the Wuhan provides, we know, some background of protection even against those strains that ostensibly are in vitro neutralized and helps to prevent the more severe outcomes. So it makes a lot of sense to base it on some sort of a bivalent vaccine that would then be given once a year instead of every few months. Thanks.
Great. Thank you, Dr. Costa. There's a couple more questions in the Q&A that we will not answer live. So I just ask you to just type the answers to the individual questions. Thank you. We will move on next to our RSV speaker. So correction, we're moving on next to talk about influenza vaccines. And so I will be introducing Dr. Shah. Dr. Tricia Shah is a clinical associate professor in the development of pharmacy practice at Chicago State University College of Pharmacy. A native Chicagoan, Dr. Shah earned her Bachelor of Science in Biology degree from Loyola University in Chicago and a Doctor of Pharmacy degree from University of Illinois at Chicago College of Pharmacy. Dr. Shah is a member of the National Pharmaceutical Association and currently serves as the Zone 3 Director and also the immediate past president of the Chicago Pharmacists Association. Welcome, Dr. Shah.
Thank you, Dr. Rogo. Thank you for this opportunity to participate in this webinar. And I think I'm waiting for control. Yes, we will get started with a pretest question. And so for our first pretest question, this is a true or false question. Changes in the seasonal flu vaccine are based on theorized antigenic changes in the influenza B virus. So true or false? Give you guys some time to answer. And then the second pre-test question for your consideration is another true and false, and it reads, hemagglutinin and neuroamidase are the antigens targeted in antiviral treatments. And again, this is a true or false question, and your answer should indicate whether or not this statement is true and or false. Okay, and so hopefully with at the conclusion of this presentation, you will be able to answer those questions appropriately. So let's get started with some influenza basics. During the 2019 and 2020 flu season, influenza was responsible for approximately 39 to 56 million illnesses, up to 740,000 hospitalizations, and between 24,000 and 64,000 deaths. And so, as we know, predominantly during the 2021 season, we did not have as many influenza-like illnesses due to the mitigations for the COVID-19 pandemic. However, as we are starting to realize, and the reason for this webinar today, influenza, along with the other viruses that are being mentioned today, are on the rise, and so we are trying to do our best to mitigate the number of illnesses as well as hospitalizations from this potentially deadly virus. And influenza is a member of the Orthomyxoviridae family, and there are 3 types of the influenza virus, types A, B, and C. Types A and B are responsible for infections in humans. However, type C is primarily responsible for infections in other species. In addition, the influenza A virus is further categorized into subcategories based on 2 surface antigens being hemagglutinin as well as neuroamidase. And we know that the type A influenza virus is responsible for seasonal flu, while type B influenza is typically associated with outbreaks, specifically those outbreaks that occur in long-term care facilities. Just a little bit more about the antigens. Of the of influenza type A. We have the hemagglutinin, and this particular antigen allows the virus to enter host cells through attachment to celiac acid receptors. And there are 16 types of this particular antigen, types H1 through H16. And then we have the neuroamidase, which allows the release of new viral particles from the host cells by catalyzing the cleavages of celiac acid. And there are 9 subtypes of this particular antigen, types N1 through N9. And these are the primary targets for the seasonal flu virus. It is also interesting to note that the only subtypes of these particular antigens that have circulated amongst humans since the 1918 pandemic are H1 through H3, and then N1 and N2. And as interesting as it may sound, as I continue to say H1 and N1, you may recognize that the H1N1 strain of influenza A was one of the main, was the strain that was responsible for the pandemic the H1N1 influenza pandemic that happened several years ago. So transitioning into some of the current influenza statistics, the CDC currently tracks influenza statistics, and they are updated weekly. The CDC site that is responsible for this is the CDC Flu View, and the website is linked here. And each week they are tracking the number of influenza cases, as well as hospitalizations and deaths. And for week 3 of this year, which ended last week, January 28th, 2023, there were approximately 87,000 lab specimens that were tested. Of those specimens, approximately 2,600 specimens were tested positive for influenza, and approximately 96% of those positive specimens were positive for the influenza A virus. And then in addition, of provider visits that occurred during that week, 2.6 of those visits were noted to be for respiratory illness, and then approximately 4,000 patients were admitted to the hospital with influenza, and there were approximately 6 deaths reported. So even though these numbers may not be staggering, we are still seeing a number of cases of influenza within our health systems. The slide, the diagrams on this slide also show or gives us some insight into how the flu is being transmitted across the United States. On the left-hand side of the screen, what you will see in green, particularly in the Midwestern states, there are low to minimal flu cases that have been detected in these states. However, in New York City, Oklahoma, and New Mexico, which are red to dark red color, those indicate that there have been very high or high numbers of the influenza virus that has been recorded in those particular areas. On the right-hand side of the screen, you'll see a diagram. You'll see a line graph that is that is showing the numbers of cases of not only flu but other respiratory illnesses. And what you will see to the left of the chart, the line with the triangle, with the red triangles, that is indicating the number of flu cases in the United States starting from week 40 of 2022 through week 3 of 2023. Which was last week. And so what you will see is that there was a sharp increase in the number of the flu cases starting at week 40. And then as we progress into week 3 of 2023, that there has been a decline. And so although the flu cases are on a decline, there's still a potential for those cases to come back up. As healthcare providers, we know that prevention of these the number of cases of flu, we know the key to preventing these cases is vaccination with the influenza vaccine. And so the the influenza vaccine is typically available starting in September of October of each year. And the seasonal composition of these flu vaccines include 2 influenza A and 2 influenza B strains. And these specific strains are based upon antigenic drift. And antigenic drift is the phenomenon where new virus variants are created by point mutations in the surface antigens of a particular subtype, resulting in small changes in the hemagglutinin as well as the neuroamidase molecules. And this antigenic drift is the basis for the seasonal epidemic of flu, which is also the reason why there's a change in the strains that are used for the flu vaccination each year. Lastly, for our flu vaccines, we have several different types. We have three specific types. The inactivated influenza vaccine, which the majority of our patients will receive. And these inactivated influenza vaccines can be grown in either an egg-based culture or a cell-based culture. We also have the live attenuated influenza vaccine, as well as a recombinant influenza vaccine. For the 2022-2023 flu season, we are the vaccines that are licensed in the United States will contain 4 strands of the influenza virus, hence the name, hence you will see that they are quadrivalent because they do contain 4 strains of the vaccine. They will contain 2 influenza A and 2 influenza B vaccines. The vaccines that are used for this season's flu vaccines are listed here. And of note, what you will see is that there are 2 strains listed for the influenza A strains, because one strain will either be grown in either an egg-based culture, or it will be grown in a cell-based culture. So we have 2 strains for the egg-based vaccines, and then we also have 2 strains for the cell-based vaccines. And so those are also slightly different. So in this chart, we have the available flu vaccines under the inactivated influenza vaccines that are grown in an egg-based culture. We have 5 vaccines. 4 of them are our standard dose, the standard 0.5 ml dose, but we also have our high dose vaccine, which is a 0.7 ml vaccine. And for the 4 standard dose vaccines, those vaccines are indicated for anyone over the age of 6 months. And then for the high dose quadrivalent vaccine, that is indicated for anyone who is over the age of 65. Then we have the inactivated influenza vaccine that is grown, that is cell culture based, that is indicated for anyone who is over the age of 6 months as well. And then next, we have our recombinant influenza vaccine, which is also quadrivalent. That is a standard dose of 0.5 mLs, and this is indicated for anyone who is over the age of 18, including our population who is over the age of 65. And then last but not least, we have our live attenuated flu vaccine. This is also quadrivalent. However, this is our intranasal. This comes as a 0.2 ml intranasal spray, and this is indicated for any individual age 2 through age 49. With the flu vaccine, next, I want to transition to talking about the flu vaccine and two populations where we want to ensure that they receive their flu vaccine on an annual basis. The first population is our elderly population. We know that older adults are at an increased risk for severe influenza-associated illnesses, hospitalization, as well as death. We also know through published research that the standard dose vaccines, our 0.5 ml vaccines, tend to be less effective in our older adults. Therefore, we want to make sure our older adults are vaccinated with either our high dose vaccine, so that 0.7 ml vaccine, or our recombinant or adjuvanted standard dose vaccines. Those are the preferred doses for our older populations, our populations greater than or equal to 65 years of age. For our high dose and recombinant influenza vaccines, those vaccines particularly have a higher dose of the hemagglutinin antigen than the standard dose vaccine, and then our adjuvanted and activated influenza vaccine has that standard amount of the hemagglutinin, but contains a an adjuvant known as the MF59 antigen. And this helps the immune system produce higher levels of antibodies to the hemagglutinin hemagglutinin antigen. Next, the next population that we want to protect from severe illness is our pregnant and postpartum women. They are also at a higher risk of severe illness and complications, and they can pass these complications on to their unborn child or their newborn child. And so vaccination for our pregnant women can occur at any trimester before as well as during the influenza season. However, if their trimester occurs during the late summer months of July and August, those women can receive vaccinations if they are available. And from what I hear from some of my colleagues, the vaccines tend to be available starting in mid to late June, sometimes mid to early July. So that is completely appropriate if the vaccination supply exists. And again, women should receive vaccination with any licensed and age-appropriate inactivated influenza virus or recombinant influenza virus. However, they should not receive the live attenuated virus during pregnancy due to a potential injury to the unborn fetus. And then, however, if they would like to receive the live attenuated vaccination, they can receive that in the postpartum months if they so desire. And with that, we will start the post-test questions. And so these are the same questions from before. True or false, changes in the seasonal flu vaccine are based on theorized antigenic changes in the influenza B virus. Is that true or is that false? Okay. And then the second post-test question, true or false? Hemagglutinin and neuroamidase are the antigens targeted in antiviral treatments. Is that true or is that false? Okay. Let's see the answers for question one. Okay, so we had approximately 30% of you guys answered true for question number one, and 70% entered false. And if you answered false, you are correct. The antigenic changes, the changes in the seasonal flu vaccine are based upon the antigenic changes in the influenza A virus. Those are those are the influenza A virus is the one that has the two subtypes, the hemagglutinin subtypes H1 through H16, and then the neuroamidase, so with subtypes N1 through N9. And then last but not least, we have our second question, which is true or false. Hemagglutinin and neuroamidase are the antigens targeted in antiviral treatments. And so this is kind of a trick question. And so, yes, they are targeted with the influenza virus. And however, when I'm thinking about antiviral treatments, these are not necessarily the antigens that are targeted in our antiviral treatments, such as Tamiflu and Baloxavir. Those typically target proteins that are made during replication. And so with this particular question, this is somewhat tricky. However, the answer that I had in mind was false, because I was thinking more so of the oral treatments, not necessarily our preventative measures for preventing the flu, which is the influenza vaccine. And so with that, I will hand it back over to Dr. Rogo for a Q&A session.
Thank you, Dr. Shaw. I'm going to actually move on to the next speaker because of time. And so I just kindly ask you to type answers in the Q&A for the questions that are targeted to you on influenza. And then at the end, we'll come back and answer any additional questions that you didn't get to. Thank you, Dr. Shaw. Okay, so we're now going to move on to talking about RSV. And our next speaker is Dr. Williams, my esteemed colleague in pediatric infectious diseases. Dr. Williams is professor of pediatrics at the Rutgers Robert Wood Johnson Medical School, where she's also the chief of the Division of Pediatric Allergy, Immunology, and Infectious Diseases. And she also serves as the Senior Associate Dean for Inclusion and Diversity at Rutgers. A native of Boston, Dr. Whitley received her BS degree in biology from the Simmons College in Boston and a medical degree from Johns Hopkins. Dr. Whitley Williams is the NMA's liaison member to the Advisory Committee on Immunization Practices at the CDC, and is also a member of our NMA Task Force on Vaccines and Therapeutics. Welcome, Dr. Whitley Williams.
Thank you so much, Dr. Rogo. Good morning, and good morning to our West Coast participants, and good afternoon to everyone else. We have a pretest for you. Each year in the US, RSV is responsible for A, 58,000 to 80,000 hospitalizations among children younger than 5 years of age. B, less than 100 hospitalizations in adults 65 years of age and older. C, less than 100 deaths in adults 65 years of age and older. And D, about 50,000 deaths in children younger than 5 years of age. The second question, early symptoms of RSV disease in children include A, cough, B, wheezing, C, rhinorrhea, D, all of the above, or E, is only cough and rhinorrhea. So thank you for answering those questions, and we'll move on to the talk. This is an overview of what I'll be speaking about, and mainly three things: the burden of disease, the clinical presentation, and active and passive immunization. I have no disclosures. to have control of the slides. Whoops. Okay, I guess I do have now. Okay, let's get started. I'm just going to try to move these windows out so I can see. RSV is the leading cause of hospitalizations in infants in the US. In fact, almost 70% of infants are infected in the first year of life, and almost all children have had at least one RSV respiratory infection by age 2. Now, premature infants born under less than 30 weeks gestation have hospitalization rates that are 3 times higher, as shown on this graph. This is an article by Carolyn Briggs Hall and colleagues. Premature infants under 30 weeks gestation likely to have 3 times the hospitalization rates compared to term infants, who are defined as equal to or older or greater than 37 weeks gestation. Almost 80% of children hospitalized with RSV under 2 years of age are perfectly healthy children. They had no underlying medical conditions. And 2 to 3% of all infants are hospitalized for RSV. So for people who are pediatric care providers, we truly see this on a yearly basis. This is a study by Wayne and colleagues, which looked at RSV-associated hospitalization rates by race. And what's interesting is that Black children were only slightly more likely to be hospitalized with RSV when compared to their white counterparts, with a relative risk of 1.2. And there were no significant differences in hospitalization rates of Black versus white children under 2 years of age. So on the graph to the right, this is looking at hospitalization rates per 1,000. And there were 3 different counties involved in this particular study. It was published in 2013, so it looked at RSV during the years of 2002 to 2009. And see, this is looking at RSV only because they looked at other respiratory illnesses. The stripes are Black children compared to the dashes or dotted dots, which are white children in 3 different counties in Tennessee, New York, and Ohio. And so if you look at the hospitalization rates per 1,000, there really wasn't that much of a significant difference. When you looked at these tall columns, which are referring to children under 5 months of age and younger. However, when you looked at the older children, not so much in the Tennessee County, but particularly in New York and Ohio, as you can see, the hospitalization rates were much higher in Black children, as represented by the Black column compared to their white counterparts in the white column. And again, in Ohio, a similar disparity. And in fact, children aged 12 to 23 months is a relative risk of 1.7 for hospitalization rates for Black children. And for those children 24 to 59 months of age, the relative risk was 2.2 Black compared to white children. This is looking at, this data is from the CDC, and I believe I have included the CDC reference. This is from the RSV surveillance, and this is looking at RSV during this current season, 22 to 23. And these are RSV-associated hospitalizations. Overall, they were 46.6 per 100,000. But what was interesting about this season, because we didn't have much of a season last year, mainly due and it was the same for influenza, and mainly because of the predominance of COVID over the last 2 years. But if we look at this, usually we see a peak in RSV in February. However, if you notice, the peak occurred in leading into November, and it really peaked November, December. So the blue line, and this is looking at age-related RSV hospitalization rates, and the blue line obviously are the younger children, 0 to 4 years of age, where we know RSV bronchiolitis or respiratory infections play a major role in hospitalizations of otherwise healthy children. But I also would like you to note that the green line refers to adults 65 years and older. And these are the two populations that are truly impacted by RSV, particularly when we look at hospitalizations. And this is a graph showing the rates of RSV-associated hospitalizations this 22-23 RSV season. And this is looking at by race, ethnicity. So the green line is overall hospitalization rates. And again, you see that peak in November, December, roughly about 5 per 100,000 hospitalization rate overall. What you see where there's a disparity and underrepresented minorities actually occurred in the Alaskan Native American Indian population, having hospitalization rates that were twice the rates seen in their white counterparts. Also, the purple is referring to Hispanic, non-white Hispanic. And those two groups were largely affected. Now, if we look at the Black population, Black children, this is as denoted in the yellow line. It looks like there was a disparity as the season started, definitely, but then did not appear to peak as we see in the American Indian and Alaskan and Hispanic populations. And the blue line is referring to white non-Hispanic. So very interesting. We are obviously, the peak has really declined. This is when we would typically be seeing the height or the peak of RSV. So what's the burden of disease of RSV disease in older adults? There was a study of about 2,300 adults, more than 50 years of age and older. This was primarily from Southeast Minnesota, so did not have a diverse population, but there are not that many studies in the past that have really documented hospitalization rates and burden of disease of RSV in adults. The incidence was about 48.6 per 1,000 person years. It covered the 2 RSV seasons. Actually, the one season was pre-pandemic, COVID pandemic, and the second one was second year was during. But actually the attack rate of 2.5%, there was a previous study published in 2003, which actually looked at RSV burden of disease in older adults, but primarily in the 1990s. So it was a long time before this has been studied, but certainly with the recent surge in RSV, particularly this year, it has brought to it, I think, increasing attention that RSV is a contender along with flu and COVID, thus the triple threat. But RSV led to 177,000 hospitalizations and about 14,000 deaths in adults over the age of 65 each year in the US. I think this is something we really need to pay attention to. As we know, influenza-related deaths are anywhere from 12 to 40,000 annually. Well, RSV is getting up there as well. So so RSV infections decreased rapidly and dramatically after March 2020. And remember, that was the beginning of the COVID-19 pandemic. And we feel that it's recognized that RSV infections declined. Why? Because it was physical distancing, children were homeschooled, masks were being worn. But we noticed the cases did begin to rise in the spring of 2021 as safety protocols were relaxed. And as of the fall of 2022, as many more children went back to school and many adults also returned to work, there was an increase in RSV activity, which I've just showed you. And this did impact on the guidelines for pembrolizumab, which is actually a passive form of passive immunization for infants who may be at risk for RSV. Seems like this is not changing very easily. Okay. Simply, I'm not going to spend a long time on this slide, but the symptoms of RSV, respiratory disease, and most of it is bronchiolitis, and it's characteristically demonstrated by rhinorrhea, decrease in appetite, coughing, sneezing, fever, and particularly wheezing. And usually on the chest X-ray, you see a hyperinflated lungs. You may see some patchy infiltrates. These are usually not bacterial pneumonias. They are truly a pneumonitis associated with RSV. Whereas RSV in adults, their clinical presentation is similar, although of course they can complain of having a sore throat, and they typically will have a pharyngitis, non-exudative, and also complain of a headache, as well as the respiratory symptoms, rhinorrhea, and cough. Usually it lasts 5 days or less. However, in adults, they can have more severe symptoms and progress to a lower respiratory tract infection, including pneumonia or even a secondary bacterial pneumonia. Those adults who are at high risk for severe illness from RSV, and we've learned more about this, particularly as we've had this peak season, are older adults who are 65 years or older, adults with chronic lung disease or heart disease, adults with weakened immune systems. Sounds familiar, right? Because these same groups in adults are at risk for influenza and COVID-19, i.e. the triple threat. And RSV also in someone who already has COPD or congestive heart failure or chronic asthma can lead to exacerbation of those conditions. So just very quickly, the diagnosis of RSV these days is real-time reverse transcriptase PCR. It's much more sensitive than doing a viral culture and even antigen testing. Antigen testing is highly sensitive in children, but not that sensitive in adults. So really in all of the surveillance studies, they are using RSV real-time PCR to make the diagnosis of RSV. Viral cultures are extremely expensive and take a long time to do. So they really are not done anymore. Serology may be done really only for research and surveillance purposes. There are 2 subtypes, which I didn't talk about in the beginning. There's a type A and type B, but there really does not appear to be any clinical significance, or at least not that we know as of date. So how do we manage RSV? It's a viral infection. It really is symptomatic treatment, fluids, antipyretics, obviously respiratory support for those who are hospitalized, whether they need oxygen or actually become intubated. And this is a disease, hopefully, that we can find a vaccine to prevent because it does cause morbidity and mortality. I'm not going to go through each of these lines, but these are the guidelines to prevent RSV in young infants. We do have a monoclonal called pembrolizumab. And as you see, remember I started out telling you that it's really the children born under 30 weeks of age that are at highest risk for RSV hospitalization. And then preterm infants, other preterm infants who may be under 32 weeks gestation, but they have chronic lung disease, or the immunocompromised, or children who remain on oxygen or on chronic steroids, et cetera. There's also a heavy burden of disease, as I showed you in one of the surveillance slides, which looked at Native Americans and American Indians and Alaskan natives. Because of their high burden, oftentimes their infants are. Pembrolizumab is used as a prevention. It's typically given monthly and a maximum of 5 months. So it was meant to cover during the winter season when RSV is predominating, is peaking. There is a newer monoclonal. It's in completed phase 2 and phase 3 trials. It's nursivimab, and it was used in healthy preterm infants over 29 weeks, as well as term infants. Now, the difference here is it only requires one intramuscular dose. And in the studies, they only looked at protection through 150 days. But the efficacy was about 76%, and it did not decline over the 150-day study period. So perhaps that efficacy might continue longer. It also was noted that the neutralizing antibody titers were 7 times higher compared to baseline at day 361. So, that's going almost a year. Of course, the neutralizing antibodies also were significantly higher than the antibody levels generated from natural infection. The only problem with this, some of the studies, they're only 3.4% Black. However, it's a global study, hopefully that will look at this more, and particularly in infants who are maybe at risk. There are vaccines that are coming. There are at least 3 vaccine candidates made by different companies. And basically what it is, the antigen, the RSV antigen has been engineered to preferentially maintain this sort of pre-fusion shape or conformation. And it displays these potent neutralizing epitopes, antigens, and that really has helped to boost the humoral immune response in older adults. And so these vaccines, and what's amazing is usually vaccine trials are done in adults and then children, and then lastly, pregnant women. But here, we do have studies ongoing in older adults and pregnant women. And the reason for this, there's a global initiative to really find an RSV vaccine for pregnant women. Why? Because RSV infections or illnesses in children under a year of age, now worldwide, RSV is the 2nd leading cause of death, second only to malaria. So it would be extremely important from a worldwide point of view to develop a vaccine for pregnant women as well as older adults. And I think we are close to achieving that goal. And just briefly to report on these results were actually presented at the ACIP in October. So it's part of the public domain because that meeting is public. But this was a phase 3 trial, which means obviously that there are usually more than 1,000 people participating in the trial. And it really is looking at efficacy, but also safety, the immunogenicity, reactogenicity, and persistence and vaccine efficacy. But what was great about these trials is they also looked at co-administering quadrivalent inactivated flu vaccine. So that's very important, right? Because if you go for your flu vaccination, if there is an RS vaccine, it would be great if we could co-administer RSV as we do COVID. These 3 vaccines, but this particular study looked at one vaccine, But it really was tremendous. The vaccine efficacy was 94%, even in older adults that had severe lower respiratory tract infections, that had comorbid conditions such as chronic heart and lung disease, as well as 70 to 79-year-old adults. And it was safely co-administered with quadrivalent inactivated flu vaccine. The safety profile looked great. So this is very promising. And in pregnant women, and there were a total of 7,400 women. This was a randomized, double-blinded controlled phase 3 study. It had about and I think what's important to understand, and this is similar to the flu vaccination story, and that is that this new vaccine had an 82% efficacy against or preventing severe RVS infection in the infants born to the pregnant women who had been immunized. And that lasted from birth through the first 90 days of life. About 69% vaccine efficacy against severe disease in these infants through the first 6 months of life. And there are studies that have looked at vaccinating pregnant women with influenza vaccine that show that their infants are also protected in the first 3 months of life. So this is terrific. The vaccine was administered the second or third trimester of pregnancy. Obviously, we tend to stay away from the first trimester. And there were no signs of safety issues for either mother or their newborn infants. So again, very promising vaccines on the horizon. And these are my references. I hope you've learned something new today. Let's go on to the post-test. Each year in the US, RSV is responsible for, and the correct answer was A. So RSV is in the US, it's responsible for anywhere from 58,000 to 80,000 hospitalizations among children younger than 5 years of age. Remember, in adults, it's responsible for anywhere from 100,000 up to 300,000 hospitalizations. The worldwide, I said D, that's in, okay, sorry about that. I should give you some, I thought people would have answered in the pretest, so I'm just going over some of these, but that's fine. I think what's important in the US, only, and I don't want to say only, but deaths in children that are RSV related, maybe about 500 at the most. But worldwide, anywhere from 100 to 200,000 deaths due to RSV worldwide, particularly in resource challenged countries. So that's why the vaccine is so important. And the second answer was all of the above. So it would have been D. So, wow, you guys did very well in both questions, but I hope you've learned ways hopefully in the future, we can prevent severe RSV disease in older adults and particularly in children worldwide. Thank you for your attention.
Thank you, Dr. Whitley-Williams. Due to time, I'm going to move on to the next speaker. We will have time for Q&A at the end, but there are questions in the Q&A box, Dr. Whitley-Williams, if you can type answers to them. Thank you. Okay, so we're going to move on to talk about the last virus that's on agenda for today, which is MPox. And it is my pleasure to introduce Dr. Whitley-Williams, who is currently the medical director of the Division of Disease Control and Chief of Tuberculosis Services at the Westchester Department of Health. Dr. Hewlett received his medical degree from the University of Wisconsin and is board certified in internal medicine and in infectious diseases. He serves as the vice chair of the board of directors of the Infectious Diseases Society of America Foundation and is also chair of our NMA Task Force on COVID-19 Vaccines and Therapeutics. Welcome, Dr. Hewlett.
Thank you very much, Dr. Rogo, and good morning and good afternoon to all of you. It is a pleasure to be able to be here. And before I start, I do want to thank Dr. Clooney for appointing me to be chair of this vaccine and therapeutics section. It's an honor to be able to serve, and it's an honor to be able to serve with our colleagues on this panel. And one of the most important things I think that we can do, and one of the most important missions which I think we have, those of us who are in a position to do so, is to try to pass along information and knowledge to our colleagues who are on this program, because you are the ones that are taking care of the patients in our communities. And I don't think that there's anything that's more important for us to do, especially during this time of Black History Month. So with that, I'll go into my pre-test. I think we have two short questions for you before we get into the actual talk. MPox, which was formerly known as monkeypox, is not related to chickenpox. True or false? The second question is, anyone can get MPox via close direct contact with lesions of an infected person. True or false? Okay, with that, we will go into our presentation on MPox. A little background here. Pox viruses are brick or oval-shaped viruses with large double-stranded DNA genomes. The pox viruses exist throughout the world and cause disease in humans and also in many other types of animals. And pox virus infections typically result in the formation of lesions in skin nodules and in some cases disseminated rash. Some of the pox viruses, such as smallpox, also known as variola virus, no longer exist in nature. Other pox viruses can still cause disease. I'll mention to you a fact for Black History Month, which some of you may not be aware of. One of the individuals who was credited with the eradication of smallpox was Dr. George Lithcott, who actually was one of my mentors. And Dr. Lithcott was on the faculty at Columbia University and spent a lot of his time on the African continent working to eradicate smallpox. Now, smallpox, which is no longer seen, was a serious disease and it was often fatal. The last case occurred in Somalia in 1977. Now, monkeypox, the virus is still known as the monkeypox virus, molluscum contagiosum, and the ORF virus, also known as the sore mouth disease. These are all members of the pox virus family or group, if you want to call it that. And infections in humans due to these viruses usually occur due to contact with contaminated animals, people, or materials. Now, MPox, previously referred to as monkeypox, is a viral zoonotic infection that is caused by the monkeypox virus, and it results in a rash that's similar to that was seen years ago with smallpox. Now, historically, person-to-person spread outside the household and mortality from MPox are significantly less than smallpox, fortunately. The rash of MPox can also be similar in appearance to more common infectious rashes, such as those observed in secondary syphilis, herpes simplex infection, and varicella zoster virus infection. So it's important, although the current outbreak seems to have subsided, if you were considering the possibility that a person might have monkeypox, these other conditions would be part of your differential diagnosis. And in fact, when you're seeing people with those types of infections, then think about MPox as well. This slide actually illustrates the appearances that you may see, papular lesions that may become sort of vesicular in appearance, and they may occur on the skin surfaces. They typically may occur on the face. They may occur also on the mucosal surfaces, especially in areas of the genitalia, the anal area, as well as on the external genitalia. And this slide actually is to demonstrate that the infection can actually pass from humans to non-humans. This is an example of the patients actually transmitted the MPox to their dog. This is another example of some of the lesions that you can see. You can see here in this slide that this could be similar to what we might see with condyloma lata or syphilis, or even you might confuse it with something like condyloma acuminata, the condition associated with human papillomavirus. Now, the incubation period varies from 3 to 17 days. Transmission may occur up to 1 to 4 days prior to the symptom onset. And so we had a similar situation, of course, with COVID, where people were infectious for a couple of days before they actually developed symptoms. And the same is true here. These people may develop, actually transmit before they actually have symptoms. Some of the common symptoms include fever, malaise, adenopathy, rectal pain, and the rash often starts on the face and spreads to the palms and soles, and the oral mucosal lesions and involvement of the genitalia often occur as well. And in fact, in the patients that we were informed about in our county, rectal pain, severe rectal pain, was actually one of the most common reasons why people required hospitalization. The other thing that can be extremely dangerous is ocular lesions. The ocular lesions may occur, and if they are not managed appropriately, can lead to visual impairment that can be permanent. Now, this virus was first isolated in Denmark in the late 1950s, and it was initially isolated from a colony of laboratory monkeys from Singapore that were going to be used for poliovirus vaccine research. Monkeypox virus was first identified as a cause of disease in humans in the 1970s in what is now the Democratic Republic of the Congo, and the first cases were described in Central and Western Africa. They noted at that time that there were at least 2 viral clades, and among these 2 viral clades, within the second clade, I think that there were subclades that were identified as well. In that particular setting with MPox, the mortality rates ranged from 3.6% in Western Africa to 10.6% in Central Africa. In the early 2000s, there were more than 10,000 cases that were described in Central Africa. And at that same time, there were actually 47 cases that occurred in the United States. So although we are talking now about an outbreak that occurred last year, from May through October to November, this was something that had been described in the United States previously. And it was, in fact, back in 2003, much to our surprise, you might like to know that there was actually an outbreak of MPox here in the US. Now, these are not, this was not for February for Groundhog Month. These are actually prairie dogs. And the 2003 outbreak of MPox in domesticated prairie dogs occurred after they shared bedding and caging with a shipment of infected small mammals from West Africa. And so this outbreak actually involved contact with pets. And this was a multi-state outbreak of monkeypox in Illinois, Indiana, and Wisconsin. And during May and June, this outbreak occurred. It was a febrile illness with vesiculopustular eruptions that occurred among persons in the Midwestern United States. The first person, incidentally, was a child with a previously reported laboratory confirmed case of severe monkeypox associated with encephalitis. The child subsequently improved and was discharged after requiring hospitalization for 14 days. And so in children, at least at that time, and this was a concern in the recent outbreak, children seem to be more severely impacted than adults. A second child during the same period of time was exposed to 3 ill prairie dogs and was hospitalized with profound painful cervical and tonsillar adenopathy and diffuse pox lesions, including lesions in the oral pharynx. And although the child had difficulty breathing and swallowing, mechanical ventilation in that child was fortunately not required. And so based upon the data from that study, which was published in the New England Journal of Medicine during that year, I think it was Dr. Reed and others who published it, as well as it was in the MMWR, the obvious conclusion is that MPox is a zoonotic disease. And the investigation at that time that included 79 cases of documented, in which there was documented isolation and identification of the virus from humans, was essentially the first outbreak that was reported in the Western Hemisphere. Infection of humans during this particular outbreak was associated with direct contact with ill prairie dogs that were being kept and sold as pets. Now, let's fast forward to our situation most recently. This is a summary of the epidemiologic features of the MPox outbreak and the public health response here in the United States from May 17th through October the 6th of 2022. Now, the index case occurred in an individual, a man in Boston. The US was the fourth country outside of Africa to be impacted. An analysis of about 2,891 US MPox cases found that up to 99% occurred in men. 94% of those for whom there was data reported male-to-male sexual contact. A total of 26,384 US MPox cases were reported during May 17th through October the 6th of 2022. You'll be interested to note that Black and Hispanic persons were disproportionately affected. 32% were Black, 31% were Hispanic, 30% were white, and the median age was 34 years. One of the things that we were very concerned about in our health department, and our concern was shared by individuals at other health departments, including individuals at the New York State Department of Health, was that the percentage of people who were actually coming in to be vaccinated to our health departments did not match with the percentage of people who were involved or impacted by the cases. And I don't have the exact numbers to show to you, but there was a very wide disparity. And our officials at the New York State Health Department were very concerned about that. Now, what was our US public health response? We were notified in our health department, I believe it was probably in June, and we were alerted to the fact that we were going to have to prepare to start vaccinating people. And we started a mass vaccination program. Our county health department, we partnered with several different clinics in Westchester County so that we would be able to maximize the number of people who were vaccinated. But another part of the emphasis was on the detection of cases, and over 26,000 cases were detected nationally. There was expanded testing that was facilitated, and of course, importantly, vaccination and treatment. And we started to prioritize with people who had known contact with cases or suspected cases. And then there was also provider and public health outreach. There was a distribution of health advisories trying to alert the practitioners and alerting the directors of the clinics about this so that we would be able to vaccinate and try to stop the spread of the disease. As far as treatment is concerned, the antiviral drug tecovirimat, also known as TPOXX, has been approved by the Food and Drug Administration to treat smallpox in adults and children. And this treatment has also been used to treat the MPox. Drugs developed to treat smallpox may be used to treat MPox. And the tecovirimat is currently indicated for severe MPox disease or for those who are at high risk for severe disease, such as our immunocompromised individuals. And so you don't treat every single case. In fact, it's only a small number of people who actually are candidates for treatment. And this is based on clinical judgment, but examples would be individuals that are having severe pain, individuals who have lesions in mucosal areas, including the eyes, or individuals who are immunocompromised. And of course, this would include our pregnant patients, and we'll go into that in a moment. And this agent may help prevent or minimize severe MPox, including the eyes, mouth, throat, genitals, and the anus. And it may provide relief for short-term symptoms such as pain, swelling, and abscesses, and long-term effects such as scarring. Now, some clinical considerations for MPox. in people who are pregnant or breastfeeding. This is extremely important. We didn't run into too many of these cases, but you have to be aware of the importance, and you have to make sure that you make the proper referrals and take the proper action to prevent disease from occurring or disease transmission. But MPox, monkeypox virus, can be transmitted to the fetus during pregnancy or to the newborn by close contact during and after birth. Adverse pregnancy outcomes, including spontaneous pregnancy loss and stillbirth, have been reported in cases of confirmed MPox infection during pregnancy. So it's important to keep this in mind. And while most non-pregnant adults with MPox virus infection fortunately experience only mild illness and recover spontaneously, pregnant, recently pregnant, and breastfeeding people should be prioritized for medical treatment if needed. So it would behoove you, if you are running into this type of situation, to call for help immediately. Obviously, the obstetricians are already involved, but calling in the pediatric infectious disease specialist as well as other infectious disease specialists would be helpful. Probable increased risk of severe disease during pregnancy. There's a probable increased risk of severe disease during pregnancy, a risk of transmission to the fetus during pregnancy or the newborn by close contact, as we mentioned. Treatment for MPox virus should be offered when indicated to people who are pregnant, recently pregnant, or breastfeeding, and the risks and benefits of treatment should be discussed with the patient using shared decision making. Now, the MPox vaccine, we'll go through the basics before we close here. The MPox, formerly known as monkeypox, is related to the virus that causes smallpox. The Jynneos vaccine is a 2-dose vaccine that was actually developed to protect against MPox and smallpox infections, but primarily it was smallpox was the impetus for this. Both doses of the vaccine are required for the best protection against MPox. Second dose is given 4 weeks after the first dose. And it's a rather unique vaccine. Early on during the pandemic, when we started vaccinating people in Westchester, we were giving it via the subcutaneous route, and the subcutaneous route required a larger dose of the vaccine. And what was discovered early on, and this was passed along to us at the health departments, was that intradermal injection was just as efficacious as the subcutaneous route. And that the important thing was that we were able to actually use less product, which meant that we had more vaccine supply to serve the public. And so we started with the intradermal injections about the second or third week that we were into our vaccination campaign. And that made a big, big difference, because you may recall during the early phases of the outbreak, we were dealing with severe shortages. And it's given similar to the tuberculin vaccine. I won't go through all of these. We will make these slides available to you, including in terms of who the CDC recommends as far as the vaccination, but you can see here, obviously, known or suspected exposure to someone with MPox, or people that have had sex partners, individuals that are in certain categories, such as gay or bisexual men, and there are a number of other categories there. And these now include laboratory workers, people that may have to work with the orthopox viruses in the laboratory setting. And finally, as of February the 2nd, it was just yesterday, the US declared an end, actually 2 days ago, an end to the MPox emergency. As a result of the outbreak, over 30,123 infections. The peak at one time was 400 new cases per day, and there were 28 deaths. So although this was an outbreak that was characterized by mild illness in most individuals, it's very important for us to understand that some people did have severe complications, and there were 28 people who died as a result of this. So at this point, I think we have to go through our post-test, and then I'll turn it over to our moderator, Dr. Rogo. Okay, first question, MPox is not related to chickenpox, and that is true. It's not related to chickenpox. Chickenpox is a varicella or herpes virus, and MPox is a orthopox virus. The next question, anyone can get MPox via close direct contact with lesions of an infected person, true or false? And the answer to that is true. Anyone can actually get this. And so although it is a disease that occurred primarily in individuals, men who had sex with men, and that was the mode of contact, we vaccinated many individuals who had come in contact with individuals who were in the household, including the mothers or others who had sons who might have been infected and had cases, and the mothers were actually doing the laundry. So certainly coming in contact with the individual, as well as with some of the items that individual is in contact with, are risk factors. So I thank you very much for your attention, and I turn it over to Dr. Rogo.
Thank you, Dr. Hewlett. That was very informational. We're down to the last 15 minutes. So what I'm actually going to do now is ask all of the panelists to come on camera so that we can do the Q&A panel for everyone. And I will begin first with actually Dr. Hewlett. There's two questions in the chat about MPox therapeutics in pregnancy. So about whether, I don't know if you're aware, if treatment can be given at any gestational age during pregnancy, and also can the vaccine be given at any gestational age? Dr. Hewlett, you are muted.
Oh, I'm sorry. Yes, as far as the treatment is concerned, it obviously is indicated during pregnancy. I think that we know that for anything that we're going to do, if it is going to occur during that first portion, that first trimester, and I know with Dr. Clooney on of obstetrics, I would ask him to comment on this as well. We're always very, very concerned about that, but certainly during the later phases of pregnancy, it should be given. And I think the other piece, of course, is one is going to have to do a very delicate benefit risk ratio if we are at the very early phases of a pregnancy. As far as the vaccine is concerned, we have been giving the vaccine when we have individuals who are pregnant. Fortunately, we were not made aware of individuals who were in the very early phases of pregnancy, but certainly it is recommended that we administer it.
Okay, thank you. And while we're on the topic of pregnancy, there's a question about the flu vaccine. What is different about the flu vaccine that it can be given during any trimester of pregnancy?
So the flu vaccine has been tested or undergone clinical trial. Individuals who have been pregnant have been included in the clinical trials for the respective flu vaccines, and so they've been included in all trimesters. Women of all in various stages or various trimesters have been included in the different trials for the flu vaccine. So therefore, it has been tested safe in these populations of women. And so therefore, it is safe and effective for women in all trimesters of pregnancy.
Thank you. And then there's a question about Synagis, so palivizumab, about availability.
I was trying to answer it in the Q&A. Yes, there was limited availability, whether that was due to decrease in the production line, given the slower season the year prior during our COVID-19 pandemic. Also, the AAP readjusted the guidelines so that it would be extended to cover more months of palivizumab for our premature infants. I think the combination of those two may have led to a shortage, but I'm not 100% sure.
And while we're on it, as a pediatrician myself, Dr. Whitley Williams, if you can comment on the change in the AP guidelines about the interseasonal spread of RSV and Synagis.
Right. So the guidelines were adjusted or changed so that we would make sure we provided protection to the premature infants, and also as they usually do receive at 5 months, but remember they usually start in October and then go through March. But the change in the guidelines allowed additional months coverage as well as starting earlier. So I think this led to, so this may have contributed, I'm not sure, but this may have contributed to the shortage. I think how do I say this? There was also knowledge that the vaccine trials were well on their way. Phase 3 trials had been completed for the RSV vaccines. And again, whether the company's response to that had anything to do with the limitation is unknown, I think, at this point.
Okay.
Dr. Rogo, if you have additional comments, please feel free to make them. You're my colleague in Pete's ID.
Yes, thank you. No, I think you answered that well. And I think you meant to mute yourself. You turned your video off instead, if you want to come back on camera. Okay. And then one more question while we're on the topic of RSV is about if you happen to know when the nirsevimab will be available. Oh, you're muted, Dr.
Yeah, I know. I don't know. Actually, one good thing that we can do is to follow clinical trials and the FDA. If you go onto clinicaltrials.gov and just type in, let's say, RSV vaccines, it will tell you all the vaccine trials that are ongoing. And the same thing with the FDA. I sit on the ACAP as the NMA liaison. So usually I will know the agenda coming up. There is a meeting coming up February 23rd and 24th. I don't know if the agenda is out yet. I have not seen it. But if the RSV vaccine or the monoclonal is on there, then, we're really talking usually about a couple of months. But at this point, I don't know when it's going to be available.
Thank you. Can you please comment on, I think it's more towards Dr. Hewlett, on the end of the pandemic declaration for COVID and MPox and how that will affect minority populations on testing, vaccination, and treatment?
Sure. I think this is an extremely important question. I think that those of us that were following the news earlier this week heard that the end of the public health emergency will be officially declared on May the 15th, I think it is, or I forget which day it is in May. What that will mean is that there will be no more support for testing. A lot of the things which we are getting right now without any cost. There may be costs that will have to be incurred for testing. There's also a concern about the vaccinations. The vaccines will no longer be provided without charge after that point. Now, health departments like ours are waiting to hear from our states to determine how we are going to respond. It's our hope that we will still be able to offer the vaccines without any charge. However, I think there is a concern about people that have insurance who are not on federally funded programs. It's my understanding that Medicare is still going to cover the cost of vaccines and Medicaid, but it's going to be up in the air in terms of the private insurers. So we'll have to wait and see how that's going to impact as far as our African-American community. I think it has been helpful that these things were available without charge. As far as the Jynneos is concerned, that's another issue. We have been providing that without any charge whatsoever. There now is actually a very large supply of the Jynneos available. And so I think that in most of the public health clinics and in most of our Article 28 clinics around New York State and in other areas, they will probably still be able to offer it because they still have it. Now, I think it'll be yet to be seen what happens in the future.
Thank you. And if I can ask the panelists, we have vaccines for 3 of the viruses we talked about today, COVID-19, MPox, and influenza. And it looks like now we have an RSV vaccine on the horizon. But one of the challenges we've had is vaccine hesitancy among our communities that are high risk. And what advice or strategies do you have for the providers on this call when they're in the room with their patient and recommending to them vaccination? How do we address vaccine hesitancy? Go ahead.
I could probably start with that. I've been involved in some sort of initiatives with the Ad Council and others. And I think the key mantra, the key is, first of all, not to be dismissive. When you have a patient in front of you and they come in very often with some preconceived ideas or notions about vaccination, is to hear them out. I think that's the first thing. And what you're trying to do as a provider is to find some common ground that you can latch onto and then begin to tout the benefits of vaccination, or to explain through some of the misconceptions they may have. Some of them are very legitimate concerns, as we know, and it's about being able to talk around those concerns and directly to them to chart that path towards a sensible discussion of the benefits of vaccination. So it's a delicate process, and it's not one that you come in with a condescending manner. You come in with a receptive, listening kind of approach. And I think that's the most important thing that will lead you into the right kind of discussion. And hopefully we'll convert that notion of, no, I don't want a vaccine, to, yes, I'm going to listen to what doc says and take a chance, at least, with it.
And if I can add, I have the luxury of seeing patients over and over for pregnancy. So I see them, once a month and sometimes more frequently in the third trimester. And what I also allow for is time. And so I tell the patients exactly what you said, the benefits of it, some of the data, break it down. But also I say, you don't have to get it today. It is a serious issue, but I understand why you would want to consider it and think about it. And so don't sort of force them into trying to get them to do it. And a lot of patients eventually come back and have the vaccine.
And there are studies that have shown, mainly through surveys, that patients, particularly Black patients, do listen to their doctors, particularly Black physicians. And so I'd like to thank Dr. McClooney for doing this webinar, but also for all the physicians and providers in the National Medical Association. You mean a lot to your patients. And so having these discussions about vaccine hesitancy are extremely important, because studies have shown that your patients do trust you. So it is up to us to have those conversations. A lot of times it's just trying to do away with the myths, addressing many of the myths that are out there, and really just giving the facts. The other message we need to have is take care of yourself, be healthy, and that way you also protect the people that you love that are right around you, particularly your mother, your grandmothers, whatever, the elderly who are particularly susceptible to influenza and to RSV now.
Thank you. So there's a question about there being less places to get COVID-19 vaccinations. And I wanted actually to direct it more towards Dr. Shaw, who's our pharmacist, Dr. Hewlett, who is in the Department of Health, about healthcare access. And how do we strategize to provide access to our communities? Dr. Shaw, you want to go ahead?
I'll go first. So definitely, as funding is starting to, dwindle for our COVID-19 vaccines, our first line of defense to administer COVID-19 vaccines are our local pharmacies. And so there, at least from what I'm hearing from my colleagues, there hasn't been a dwindling supply of the COVID-19 vaccinations. And so any local pharmacies, and I know there have been reports of reduced hours and reduced pharmacy hours for these in order to receive them at a particular vaccine with a particular pharmacy within the community. However, making appointments, I know, especially for our patients with smartphones on the Walgreens app, there's the opportunity to go in and make the appointments so you don't have to wait in line. As soon as you get there, they will take you and give you your vaccination, as soon as possible. And then on the other hand, if not available at a clinic, I know a lot of our public health facilities within, I'm based out of Chicago, and so those facilities as well have varying supplies of COVID-19 vaccines. So it's just a matter of just looking up what's in the area and just going ahead and getting and supplying that information to the patients who are willing to receive the vaccine or another vaccine.
And I think Dr. Shaw has really summarized it very well. In our health department, we are actively scheduling clinics. We are having standing clinics that are going on twice a week for infants through the adults. And we're hoping that we'll be able to continue that. We have actually served as a distribution point for other medical facilities around the county. So I think the only thing I can say is that I hope that we will continue to get a supply of these vaccines. And as long as we do, then we will continue to facilitate it. We also have been operating what we call pop-up clinics in various parts of the county. We've had clinics at schools, we've had clinics at churches and community centers and other places around our county. And I know that other health departments are doing the same thing, and I hope that we can continue.
Thank you. We are at the hour. So thank you so much to the speakers. I'm going to hand over now to our esteemed president, Dr. Clooney.
Thank you very much. As it goes without saying that this was really an outstanding webinar. Thank you so much to our speakers, Dr. DaCosta, Dr. Hewlett, Dr. Shaw, and Dr. Whitley Williams, and to our expert moderator, Dr. Rogo. You always do an excellent job. And in the words of Dr. Hewlett, take some of this back to your patients and your colleagues. And also remember that this is a CME program, and so don't forget to claim your CME. And the webinar will be available on our website for at least 6 months. And so anyone who wasn't able to participate today can view it at a later date. So I'm going to end with that, and thank you all so much for participating and for your questions, and happy Black History Month.